This is Rob Kilmer, sorting through the facts on healthcare reform. That's what we're doing this week on You Defend It. Welcome to You Defend It. The phone number to call into the show is 772-1290. As always, callers to the show will need to take a position, be able to defend it with an argument that is factual, not emotional. And if you can't make your point without insulting someone, you can't make your point on this show. Callers and guests on the show are going to be treated with complete respect. For my part, I will ask questions that matter and give people the opportunity to answer. My website is www.youdefendit.com. That's youdefendit.com. You can give me your comments on the show anytime. By Friday of each week, I will have the topics up for the next show. You can also visit my blog through the site. You can read my posts and leave your own. The lineup for the Sunday talk shows will also be posted there on Saturdays at some point, if they are posted online by then. You can always listen to my show live on streaming audio on www.wnbf.com, and my show is then uploaded to youdefendit.com later on Saturdays, and you can listen to it there if you were not able to hear it live. Finally, there are new debate suggestions and debate registration sections on the website. The July 12th debate at Binghamton University. If you have questions that you would like us to ask the debaters, and the topic for the debate is the role of the Supreme Court Justice, please do so. It is mandatory if you want to attend the filming of the pilot. You have to pre-register at youdefendit.com website. We have to be able to tell them in advance how many people are going to be there. All right, last week we talked about health care, and a lot of the comments focused on the Canadian health care system and how we want to avoid that. And this week, President Obama, there was reaction, I should say, in Congress to President Obama's plan. So this week I want to go through some of the facts, the actual facts of the Canadian health care system, and go through the reaction to Obama's plan. Okay. This is from the Denver Post, June 7, 2009. And I told, I cannot recall which caller it was last week, but I did say that I would find out as many facts as I could on the Canadian health care plan. And so this is my effort. I found this article from June 7, 2009. In the Denver Post. The headline is Debunking Canadian Healthcare Myths by Rhonda Hackett. And I will now read it to you, most of it. As a Canadian living in the United States for the past 17 years, I am frequently asked by Americans and Canadians alike to declare one healthcare system as the better one. If the only way we compare the two systems was with statistics, there is a clear victor. It is becoming increasingly more difficult to dispute the fact that Canada spends less money on health care to get better outcomes. As America comes to grips with the reality that changes are desperately needed within its health care infrastructure, it might prove useful to first debunk some myths about the Canadian system. Myth: taxes in Canada are extremely high, mostly because of national health care. In actuality, taxes are nearly equal on both sides of the border. Overall, Canada's taxes are slightly higher than those in the U.S. However, Canadians are afforded many benefits for their tax dollars, even beyond health care. For example, tax credits, family allowance, cheaper higher education. So the end result is a wash. At the end of the day, the average after-tax income of Canadian workers is equal to about 82% of their gross pay. In the United States, that average is 81.9%. Myth: Canada's healthcare system is a cumbersome bureaucracy. The U.S. has the most bureaucratic healthcare system in the world. More than 31% of every dollar spent on healthcare in the U.S. goes to paperwork, overhead, CEO salaries, profits, etc. The provincial single-payer system in Canada operates with a 1% overhead. Think about it, it is not necessary to spend huge amounts of money to decide who gets care and who doesn't when everybody is covered. Myth: the Canadian system is significantly more expensive than that of the U.S. 10% of Canada's GDP, that's gross domestic product, is spent on health care for 100% of its population. The U.S. spends 17% of its GDP for 85% of its population. And millions within that group have inadequate coverage. In essence, the U.S. system is considerably more expensive than Canada's. Part of the reason for this is uninsured and underinsured people in the U.S. still get sick and eventually seek care. People who cannot afford care and wait until advanced stages of an illness to see a doctor, and then do so through emergency rooms, which cost considerably more than primary care services. What the American taxpayer may not realize is that such care costs about $45 billion per year, and someone has to pay for it. That is why insurance premiums increase every year for insured patients, while copays and deductibles also rise rapidly. Myth: Canada's government decides who gets health care and when they get it. While HMOs and other private medical insurers in the U.S. do indeed make these decisions, the only people in Canada to do so are physicians. In Canada, the government has absolutely no say in who gets care or how they get it. Medical decisions are left entirely up to doctors, as they should be. There are no requirements for pre-authorization whatsoever. If your family doctor says you need an MRI, you get one. In the U.S., if an insurance administrator says that you are not getting an MRI, you're not getting one, no matter what your doctor thinks. Unless, of course, you have the money to cover the cost yourself. Myth: there are long waits for care which compromise access to care. There are no waits for urgent or primary care in Canada. There are reasonable waits for most specialist care and much longer waits for elective surgery. Yes, there are those instances where a patient can wait up to a month for radiation therapy for breast cancer or prostate cancer, for example. However, the wait has nothing to do with money per se, but everything to do with the lack of radiation therapists. Despite such waits, however, it is noteworthy that Canada boasts a lower incident and mortality rates than the U.S. for all cancers combined, according to the U.S. Cancer Statistics Working Group and the Canadian Cancer Society. Moreover, fewer Canadians, 11.3%, than Americans, 14.4%, admit unmet health care needs. Myth: Canadians are paying out of pocket to come to the United States for medical care. Most patients who come from Canada to the U.S. for health care are those whose costs are covered by the Canadian government. If a Canadian goes outside of the country to get services that are deemed medically necessary and are not available at home for whatever reason, the Canadian government, where you live, fully funds the cost. Those patients who do come to the U.S. for care and pay out of pocket are those who perceive their care to be more urgent than it likely is. Myth: Canada is a socialized healthcare system in which the government runs hospitals and where doctors work for the government. Princeton University health economist Uwe Reinhardt says single-payer systems are not socialized medicine but social insurance systems because doctors work in the private sector while their pay comes from the public source. Most physicians in Canada are self-employed. They are not employees of the government, nor are they accountable to the government. Doctors are accountable to their patients only. More than 90% of physicians in Canada are paid on a fee-for-service basis. Claims are submitted to a single provincial health care plan for reimbursement, whereas in the U.S. claims are submitted to multiple insurance providers. Moreover, Canadian hospitals are controlled by private boards and or regional health authorities rather than being part of or run by the government. Finally, myth: there aren't enough doctors in Canada. From a purely statistical standpoint, there are enough physicians in Canada to meet the healthcare needs of its people, but most doctors practice in large urban areas leaving rural areas with bona fide shortages. This situation is no different than that being experienced in the United States. Simply training and employing more doctors is not likely to have any significant impact on this problem. Whatever issues there are with having an adequate number of doctors in any one geographical area, they have nothing to do with the single-payer system. And that's the end of that article. So I hope that brings some balance to the discussion of Canadian healthcare. All I ever hear about Canadian healthcare is that it's socialized medicine and long waits and the care is poor. Here is the second article and the last article I'm going to read on the Canadian healthcare system. This is from something I found online called the Organic Consumer Association, written by a woman named Maggie Fox on May 31st, 2006. Despite complaints about long waits for services, Canadians are healthier than their U.S. neighbors and receive more consistent medical care, according to a report released on Tuesday. A telephone survey of more than 8,000 people showed that even though Americans spend nearly twice as much per capita for health care, they have more trouble getting care and have more unmet needs than Canadians do. The survey was done by Harvard Medical School researchers who include members of the Physicians for a National Health Program, which advocates for a national health program in the United States. These findings, quote, "These findings raise serious questions about what we're getting for the $2.1 trillion we're spending on health care this year," end quote, said Dr. David Himmelstein, an associate professor of medicine at Harvard. "We pay almost twice what Canada does for care, more than $6,000 for every American, yet Canadians are healthier and live 2 or 3 years longer. Canadians had better access to most types of medical care, with the single exception of pap smears," Himmelstein and colleagues wrote in the study published in the American Journal of Public Health. Quote, "Canadians were 7% more likely to have a regular doctor and 19% less likely to have an unmet health need. U.S. respondents were almost twice as likely to go without a needed medicine due to cost. 9.9% of U.S. respondents couldn't afford medicine versus 5.1% in Canada," end quote. The researchers found that U.S. residents had higher rates of diabetes, arthritis, chronic lung disease, high blood pressure, and obesity. Quote, "Most of what we hear about the Canadian health care system is negative, in particular the long waiting times for medical procedures," end quote. Dr. Karen Lasser, an instructor of medicine at Harvard who worked on the study, said in a statement, quote, "But we found that waiting times affect few patients, only 3.5% of Canadians versus 0.7% of people in the U.S. No one ever talks about the fact that low-income and minority patients fare better in Canada," end quote, she added. Finally, based on our findings, if I had to choose between the two systems for my patients, I would choose the Canadian system hands down, said Dr. Karen Lasser. Okay, that, I hope, brings some balance to the conversation we have about Canada. And another thing to remember about wait times, and I read this in another article after the show last week, and I should have printed it, but I didn't. When considering how long it takes to get in, it's critical to remember that in Canada you have 100% participation by the public. So it's a system that everybody's in, so they more likely do need more doctors. But the fact that there are longer wait times is not attributable, from what I've seen, to any bureaucracy, but rather to the fact that everybody's in the program. In the U.S., when you talk about wait times, you're talking about people who have insurance, and that's a statistically lower number than the people in Canada, and that affects how long people have to wait. If the list of customers is shorter, you can get to the bottom faster, and that seems to be a difference between us and Canada. All right. When we come back, I will try and get through by 8:30 or so, when we're going to have a break for local news. the opposition so far from a doctor's group to Obama's health plan. I think it is, like most things we talk about on this show, it is important for what it doesn't say as much as it is for what it does say. We'll be right back. You are listening to You Defend It with Rob Kilmer right here on News Radio 1290 WMBF Binghamton. Welcome back to You Defend It with Rob Kilmer. We are talking today about health care, and I, in the previous segment, read to you what I would characterize as the counter-argument on Canadian health care. We don't hear much of that here, particularly from in the midst of the debate over health care reform. But Obama did announce his version of reform, his idea of reform, and I want to go over, this is a June 10th article, and I'll try and get to your phone calls before 8:30, but I've got to get through this article first. Doctors Group opposes public health insurance plan. As the health care debate heats up, the American Medical Association is letting Congress know that it will oppose creation of a government-sponsored health insurance plan, which President Obama and many other Democrats see as an essential element of legislation to remake the health care system. While committed to the goal of affordable health insurance for all, the association had said in a general statement of principles that health services should be provided through private markets as they are currently. It is now reacting for the first time to specific legislative proposals being drafted by Congress. In the presidential campaign, last year, and in a letter to Congress last week, Mr. Obama called for a new public health insurance option, which he said would compete with private insurers and keep them honest. But in comments submitted to the Senate Finance Committee, the American Medical Association said, the AMA does not believe that creating a public health insurance option for non-disabled individuals under age 65 is the best way to expand health insurance coverage and lower costs. The introduction of a new plan threatens to restrict patient choice by driving out private insurers, which currently provide coverage for nearly 70% of Americans. If private insurers are pushed out of the market, the group said, the corresponding surge in public plan participation would likely lead to an explosion of costs that would need to be absorbed by taxpayers. The group has historically had a strong lobbying operation supplemented by generous campaign donations. Since the 2000 election cycle, its political action committee has contributed $9.8 million to congressional candidates, according to data from the Federal Election Commission and the Center for Responsive Politics. Like America's Health Insurance Plans, a lobby for insurers, said Tuesday that the government plan proposed by some Senate Democrats could, quote, dismantle employer-based coverage and significantly increase costs for those who remain in private coverage, end quote. Like Mr. Obama, the association wants Congress to cut payments to private Medicare Advantage plans. The White House says Medicare pays the private plans 14% more than it would cost the government to care for the same people in traditional medical care. Okay, because I ran a little long in the first segment, I'm going to get to we're going to break here in just a minute for local news. But when we come back, we will talk about what the American Medical Association has really said here, and go over that for the better part of the second half of the show. You are listening to Rob Kilmer, and You Defend It. Welcome back to You Defend It with Rob Kilmer. Phone number to call into the show is 607-772-1290. And we're talking about health care. Now, I want to go through briefly what the American Medical Association did not say. They did not say what their alternative is to solve this problem. Nothing. This is a perfect example of telling us what not to do to solve a problem without offering what to do to solve the problem. When the American Medical Association says, and this is a paragraph in the article I just read. The introduction of a new public plan threatens to restrict patient choice by driving out private insurers. Here's my question. What kind of job have the private insurers been doing? Why should driving them out not be the goal? Why on earth are we preserving something that doesn't work? I mean, the entire thrust of this article by the American Medical Association says, if you take these steps, then things are going to change. And my point is, right. If all goes well, that's exactly what will happen. Let me see who I have here. I got line 1. Are you there? Anyone on there? Hello? Are you there?
Sound like I'm getting an echo of my voice.
Okay. How about now? Hello, you there? I'll get back to the phones in a minute. You know, I don't think it's any coincidence that the people who are opposing this have a strong lobbying operation in Washington. I mean, this is really an article that gives reasons of why they want to preserve what they already have. Let me try again to pull up line 2 here. You there?
Hello?
Hello?
Can you
hear me?
I can hear you. Can you hear me?
Yep. Go ahead.
Okay, I'm Lucas.
Lucas.
Oh, all right. Now, I'm getting a little bit of feedback on my end, but I'll try to get my point through.
All right.
One of the problems when you compare different countries with different healthcare systems is they often use other data. Because, for example, in for mortality rate,
right.
The United States is the only country that counts stillbirths as part of the infant mortality rate. And very often the children who are die in the first few days of life, usually the very premature, they are not counted by most countries. But the thing is, each country uses different years. I mean different days of what. Some are supposed to go 1 day, some will go 2 days, some go 3 days.
Let me ask you this. Do you have your radio on?
No, it is off.
Oh, okay. Well, go ahead.
So, that's the problem. I mean, I'm hearing the echoing coming in on my own phone, so I don't know if it's a problem with my phone or something on your system.
Okay. Go ahead with your point.
That's one thing. And as far as, someone saying, one article in Canada, and the thing is in this country you have a large number of immigrants coming in from other countries, and many of them seem to be chronically ill. I think from one estimate that I've seen is that 1 out of 4 illegal immigrants coming here is so chronically ill that they're really in need of immediate medical treatment. And when you have a situation where virtually every illegal immigrant coming in from a country like China has hepatitis, and that this hepatitis has progressed to the point where they are either have liver cancer or they're about to get liver cancer, it may be that other countries are deliberately waging an economic war on the United States by sending their chronically ill patients to the United States for the U.S. to bear the cost. So you could say, well, you have when you're dealing with people who already have advanced health problems coming to this country, let's say you're only able to save 2 out of 3. You can have that could give us a much higher relative cancer mortality rate than countries that are exporting their chronically ill to our country. And for example, even if, let's say, a country like Canada is sending chronically ill patients to the United States, if those patients come to the United States...
Let me just slow you down a little bit with that. Do you have any evidence whatsoever that there is a systematic effort by Canada to send their chronically ill here?
No. But I'm saying that there is evidence that just China is.
Well, I mean, that's just as pertaining to the U.S. and Canada, and this was kind of hotly debated last week. I just want to stick to as many facts as we can. I've never seen anything to indicate that Canada has embarked upon a campaign to I don't know, bus their chronically ill here for care. And with universal health care in Canada, I don't know why they would need to. But just on the facts that I've been able to gather since last week, I think it's worth debating how much we pay for health care. And that was my whole point last week. We never really get down to the brass tacks of why things cost so much here, so much more here. Other countries seem to be able to provide at least as good or better care for half the money. And and you've got the insurance industry, or the American Medical Association, they are aggressively opposing changing this without offering an alternative, and I think that speaks volumes. I think that there's money to be had and money to be kept, and until a reasonable alternative is offered, it's fair to view opposition alone skeptically. I got to get to 3 more calls, so thanks for calling in.
Okay.
Thanks. Okay, I have, of course, Frank, are you there?
Hi there, Rob.
How are you?
You did a good job on that one. You pushed the right switch.
Well, it's harder than it sounds.
Hey, I got a couple comments.
Okay.
I liked your Milsonian logic. If it don't work, drop it. I'd say let's drop the Postal Service and all of Congress.
Well,
I just had to say that.
We can drop the state Senate right now and nobody noticed because they're not doing anything.
I'd say you are exactly right. Got 2 comments about the healthcare system. I think it does need some improvement. The biggest change that I've seen, and I've been in it quite a while, is the nurse practitioner program. That has been just a fantastic improvement. I think there is need for some sort of clinic access for, the poor, low-income people.
Okay.
I also think that Obama's health care system, I think it's at this point academic. I think there's very little chance it'll pass unless it's modified a lot, and I think for 2 reasons. CBO has come out and given figures for the Obama health plan, $1 trillion. Now, what people don't realize is that this first iteration of the Obama plan takes care of about 1/3 of the people who are uninsured. That means we're talking about $3 trillion.
Okay.
If you go through a linear extrapolation, which I'm doing. Also, another thing is government estimates are usually off by a factor of 2 to 4 from what I've seen for big programs. The Blue Dog Democrats, who are fiscal conservatives, they're right now meeting with moderate Republicans to go over this plan. So I think it's dead in the water. I think Obama has to go back, do his homework, and change this quite a bit.
Well, I think that something's going to happen. I think there's going to be something passed, one way or the other. And I think that's a good thing.
Yeah, I think it's a good thing.
We were not going to have that last time around.
We need fixes.
I agree.
But I'm not sure whether we need to do a 180-degree turn here at this point.
And maybe the point was never to get that. Maybe the point was to get the conversation started and make a big improvement on his watch, which nobody else is. Hillary wasn't able to do it, and I don't think there was much of a priority. It was much of a priority in the last administration. I'd like to see anything that makes us more competitive and that helps.
Yeah, me too.
Well, thanks for calling, Frank.
Bye-bye.
Bye. All right, I will try here. Lad, do I have that right? Hello?
Yes.
Welcome to the show.
First time I've heard your show. It's a good show. You're an honest broker. I appreciate that.
Oh, well, thanks. That's about the best thing I can hear on this show.
I'd like to make a couple of points, though.
Okay.
A big part of the reason why private insurance goes up way faster than inflation and has for the last 20 years is cost shifting caused by Medicare and Medicaid, where they underpay the providers, the doctors and hospitals, and so the private insurance is billed way more to make up for that.
Right.
I don't see any change in that policy at this point. Another thing is that other countries don't suffer is the tremendous burden on the healthcare industry for tort, for punitive damages that are with no end in sight. And it's a good idea to punish bad doctors, but this has become a bonanza for attorneys. And whenever, particularly President Bush tried to discuss tort reform, he was slapped down by the Congress, who are made up of or supported by trial attorneys.
Those despicable lawyers. Let me ask you
now,
this,
you have to have lawyers, but that is part of the problem, and I don't see that getting fixed under this Congress and this administration.
No, and the other day, Obama made it clear, I think, in a speech to the American Medical Association, that he wasn't going to be looking at tort reform. But,
right.
But let me ask you this. Let me ask you your opinion of this. This was in the article I just read from the American Medical Association. They support a cut in payments to Medicare, to private Medicare Advantage plans. The American Medical Association does. Why would that be? I cannot figure that out.
I can't figure that out either. But another thing that's not parallel between America and the rest of the world is that we do most of the primary medical and pharmaceutical research, so that sometimes what appears to be cheaper in, say, Canada is that they're piggybacking onto our research,
which is expensive.
And so it's easy, for instance, to call a pharmaceutical company greedy when they charge a tremendous amount for a drug. But for every drug that works, that doesn't have side effects that are prohibitive or that for whatever reason don't pass the regulatory muster, for everyone that does, there are 50 that don't, and that has to be paid for. So the question is, do you want to shift that cost to the taxpayer? And if we do that, will the research still get done? And that's an open question. That's
a valid point. And what I have heard people say is, why not let government do some of the research? Because then you would have two things. Number one, you would be able to, if the government were part of it, you would be able to expedite the process of approval if they were part of the research from the beginning. And secondly, there would be, I would presume, funds available.
Well, part of the reason why that hasn't been done, and maybe I think that herbal supplements could be an area where the government could step in, because they can't be patented because they're natural. So there's no way that a company can afford to do that kind of research, because it can never result in a patent. Part of the reason why they don't is that the government has said, look, to the pharmaceutical companies, if you're going to get a patent, you're going to pay for the research.
Right.
And then if you have a government pharmaceutical partnership, then it muddies the waters in terms of who deserves to patent the medicine, and before you know it, you're down a slippery slope where only the government has the right to the patent, and then
or you come up with something,
and then all the profit motive that drives this good research is called into question.
Well, I say we're in the middle of a crisis, and the crises tend to bring about creative solutions. Your point is well made. Maybe it's time for a collaboration with the government and private industry, which would lower the cost to private industry for research and development. However, the private industry gets the patent. even though the government may have paid for part of it, taxpayers may have underwritten it, as far as advancing the overall goal of lowering health care costs, maybe that's a sacrifice or a change that has to be made.
I think that's a good point.
I got to get to a couple more calls here.
Okay, I'd just like to say very quickly that remember, this is the government that gave us the $2,500 toilet seats and the $150 hammers. So 1%, we're never going to get 1% overhead if this is a government-run thing.
But have you ever heard of that toilet seat breaking? That's my question. Okay.
Thank you.
Thank you.
Bye.
Bye. Okay, I'm going to try and get John, you there?
Yes, I am, Rob.
Welcome to the show.
Thank you. Good morning.
Morning.
I'm calling about the beginning of the show. I was listening to it mobile-wise, so I might not have caught the end of your statistical
Okay.
thing. But I have a problem with that. It's not so much that the statistics are wrong. It's that they're incomplete.
Well, and I think all of them are.
Yeah, well, I think the major thing is when we keep comparing the U.S. with Canada, what we neglect to take into consideration is you're talking about a population of 300 million as opposed to 33 million.
Right.
Okay? Now, anybody who knows business and economics knows of the law of diminishing returns.
Okay.
You cannot say, if you extrapolate Canada's proportion of GDP up to 300, it would remain the same. It wouldn't. The higher you get to 100%, the more expensive it is.
Okay.
If you understand the point I'm trying to make. In
I
other
do.
words, what I'm trying to say is we have a one-way flow. I mean, this is documented, that we have the doctors coming from Canada to the U.S., we have people coming for treatment to the U.S., but not the other way around, because Canada does not have all the resources we have.
And that may be true because Canada, you got to also remember, though, that Canada has 100% participation. I mean, everybody's covered. So there are no conversations at the window in Canada about whether or not you have insurance. And
that's my point. But my point is this. You can do that with a smaller population, but if you think the same rule, the glove fits all, the higher you get in population numbers, that's a miscalculation. It doesn't work that way.
Okay.
I mean, if Canada was suddenly to explode to 300 million, then would they have the same GDP proportion? Well, business economics tells you there's no way that could happen.
Well, the theory on the other side of that, though, is that with 300 million people, their GDP would increase significantly with that much more being produced.
Right, but then so would their other social programs. Don't forget, we have all these other social programs. And your last caller hit the nail right on the head when he said, like I said, we have the resources. We don't hold back on research, development. Canada is not, they're not that involved. They don't spend that kind of money. And when they do send people over, it's because certain treatments are not available in Canada because they don't have
right, but
the advanced medical.
And I don't know if you heard this part of what I said. When those people come here to get from Canada to the U.S. for a treatment that is not available in Canada, Canada pays for it.
I know they pay for it. But the point is, why do they have to send them there? Why doesn't Canada have that treatment available?
Well, that's a good point.
It's expenses that they're not spending.
That's a good point. And research and development, those are billion-dollar expenditures.
I mean, I still think my problem with the statistics is this: is when somebody like the woman who wrote the article, you would go, she's comparing apples and oranges. She's comparing managing health care for a population of 33 million as opposed to 300 million. And then don't forget, Canada doesn't have all these illegal immigrants we have.
Well, and
I mean, we got these people walking into hospitals, and they're getting treatment in this country. If Canada had suddenly to, take on the expense of, what is the estimate, up to 10 million illegal immigrants, that would be a drain on, that would just keep adding to their costs. But these things all factor in.
I agree. I think it all factors in. And what I try and do on this show, particularly when I hear something like last week, about comparisons to Canada, I try and come back the next week and get as much as I can and bring some balance to it. But you're right. I mean, if this issue wasn't complicated, it would have been resolved. It's complicated, but it still needs to be resolved. Factoring in everything we have talked about today. I think you're right.
Well, thanks for taking my call.
Thanks for calling in. All right, I'm going to attempt one more for a break here. Bob, are you there?
Yes, I am. Can you hear me?
Yes, I can. Thanks for calling in.
Oh, sure. And thanks for taking my call, Rob. I guess I have a couple of points I want to make. I'll make them very quickly.
Okay.
And it kind of plays into your previous caller. Unfortunately, I think many people could sort out information and come to a reasonable conclusion if they had facts. The problem with gathering facts is that whoever does the research impacts radically the outcome of the research. And so it's very difficult to get raw facts that people can digest. I also think that without tort reform, you're not going to get very far in terms of the cost of medical care. You know, doctors perform excessive medical testing to protect themselves. I also hear people talking about the vast number of uninsured. Now, I'm not sure whether every state in the union is similar to New York State, but in New York State, we have Medicaid. And Medicaid for the uninsured kicks in if you spend X amount of dollars on your medical care, which is probably equivalent on some level to what people who have insurance through their work end up paying for that coverage. So this idea that this vast number of Americans are uninsured is kind of misleading. Most states in this union have some form of Medicaid that will kick in at some point, whether it's catastrophic medical problems or lesser medical problems. You know, if you spend X amount of dollars, then you have Medicaid. And I guess finally, I don't believe that the government, this government, our government, runs anything well and cost efficiently. The VA system is a in-country perfect example of the poor job that federal government does in managing most of its systems. You know, the budgetary deficit, whether you look at the federal, state, county, or city levels, is a perfect example. If we ran our families the same way, we'd all be living in the street.
I agree with that 100%. But I also think that the answer is to reform these agencies.
Well,
it's easier said than done, but...
Well, it's easier said than done, but I think the closer you get to the level of people versus the level of government, the better off you are in terms of whatever reform that is. The problem is you have vested interests, you have, whether it's the AMA or whoever,
right,
and it becomes twisted, distorted, and with that, expensive.
Right, and you had the AMA responding to Obama's proposal with, here's why you shouldn't do it. Not a word in there about how to solve the problem. And that's how we keep talking about things.
A simple fix, simple in a philosophic way, would be tort reform, and if the feds want to get involved, kick more money and lower the cutoffs for Medicaid, state by state. So, okay, instead of having to spend $500 a month for your medical care, the feds kick in $250 of that. All you have to spend is $250, whether it's on prescriptions, dental, you name it, and then you have Medicaid, and it'll pick up the tab.
Okay. I gotta end it here. I got a couple things to get to before the end of the show, but I appreciate you calling in.
Thank you for taking my call.
Sure thing. Thanks. Bye. All right. I think a lot of good facts out there today. There's, like everything else in this country, the hard issues are complicated. And the sooner we acknowledge that, the sooner we'll be able to move away from talking points and catchphrases and socialized medicine. You got to break it down. You got to be willing to put in the time, put in the work. I'm not talking about my callers, by the way. I'm talking about our government. And do it even though it's hard. There are no simple solutions. And whenever there's a meeting, you get one group walking down the driveway of the White House and then in front of 20 cameras giving a 10-second soundbite. And then the White House responds with a 10-second soundbite over an issue that will take 1,000 hours to figure out if somebody's willing to put in the time. And that's why it doesn't work. And that's why we try on this show to get to the facts behind the 10-second sound bites. as best we can. All right, a reminder on the debate. It is July 12th, 3 p.m. at Binghamton University at Waters Theater. You must pre-register in order to be let in for the filming of the pilot. And then as soon as it's filmed, I will be taking it to every major network with I would have said the hope, but as this gets closer, with the expectation that a network will take it and run it and show America how public issues, how current events, how important national topics should be discussed. The You Defend It debate series, particularly the people that I have involved in it, dedicated to taking these hard issues apart and making people accountable for what they say. And a lot of them want to be. You know, the people who are involved in this debate, they're eager to get up there and defend their positions. The problem for them in the past has been there's no place to do it. You can't expect to be able to do it on cable. Those are shout fests. Talk radio doesn't help you either, except for this show. And being able to put together a format that has the dignity that the issues deserve. I mean, if you attend this debate, you will see what looks like a presidential debate. I mean, down to the furniture. But more importantly, what you will also see is people defending their own positions. That's the rule. Giving America something to believe in, something to embrace, rather than something to reject. You can't solve problems by rejecting solutions. You can only solve problems by arriving at solutions. And that's what these debates are going to do. But you have to go to my website, www.youdefendit.com, to pre-register, because I have to tell SUNY or Binghamton University in advance how many people are going to be there. That's going to determine their staffing. Okay, thanks for listening to You Defend It, and we will be back next week. I am Rob Kilmer.